Hello everyone. So we are back again. Today we'll be discussing the role of imaging in neonatal respiratory distress. So before we begin the topic, we will be mostly dealing with the chest X-rays. And neonatal respiratory distress is one of the most common condition for which neonatal ICU admissions are done. And if you get an ICU posting or you regularly deal with the ICU patients, then this is one of the very common indication for which the imaging is done. And it's not just one imaging, follow-up X-rays are being done, and it's advisable that I'll advise you that always look at all the X-rays that are available to you and not just one X-ray. So I have divided basically the role of imaging in neonatal respiratory distress into two parts. In the part one that we will be covering today, we'll be covering the medical causes of respiratory distress. And in the second part, we'll be dealing with the complications of ventilation, as well as we'll be dealing with the surgical causes of respiratory distress, right? So let's get started. So respiratory distress, what is respiratory distress? What do we mean by respiratory distress? It is basically a symptom and not a disease. There is increased work of breathing. Patient has labored breathing. The child is basically just being born and has labored breathing, and which includes the following criteria. Patient can have nasal flaring, patient can have tachypnea, and patient can have grunting, and patient can have chest retraction. So these are the clinical symptoms by which the clinician diagnoses, okay, this child is having some difficulty in breathing, and now we want to diagnose that what is the cause of this respiratory distress, and that is where the role of imaging comes. Right. So we have basically divided the respiratory disorders into diffuse neonatal lung disorders. Then we have some focal neonatal lung disorders, and some disorders that can be either focal or diffuse. Right. So among the diffuse neonatal lung disorders, we have to first see, okay, what is the age of the patient that we are dealing with. If we are dealing with a preterm, then surfactant deficiency disorder is one of the foremost cause for which the respiratory distress can occur. If it is a full term, then retained fetal fluid, that is also called the transit tachypnea of the newborn, is one of the many most common cause for which the patient can have respiratory distress. Then again, if patient has meconium stained liquor, then the patient can have meconium aspiration syndrome. Then there can be some diffuse developmental disorders also. Patient can have congenital surfactant dysfunction disorder or congenital pulmonary lymphangiectasia. Right. So these are the causes which are common in the full term. Then some causes which can be seen in both the preterm and the full term. They can be alveolar growth disorders. There can be some kind of vascular congestion due to some or the other cardiac diseases. Right. So among the focal neonatal lung disorders, what you will see are mostly these are the surgical causes, right? Only a part of lung is involved. So patient can either have a congenital lobar inflation, congenital pulmonary airway malformation, or bronchopulmonary sequestration. Among the causes that can be either diffuse or focal, patient can have a pneumonia, because pneumonia does not have any predilection. It can happen in any part of the lung, right? So distribution of pneumonia is something which is non-specific, and rarely the distribution, it will point towards the pathological organ in a pathological organism in a neonate. Right. Then pulmonary interstitial emphysema is basically a complication of mechanical ventilation that we'll be discussing in the next lecture. But yes, it can be either diffuse or focal based on what is the location of our endotracheal tube and what is basically the position of the baby. Then again, if the aspiration is due to some congenital anomaly, it can have a positional variation, and it can either be a diffuse one or it can have a focal progression. So once we have seen that what all causes can be the cause of respiratory distress, we now go towards the detailed description of them. So what all are we trying to discuss? We are trying to discuss the role of imaging in differentiating the various etiologies of respiratory distress. Then the classification we have seen and the differential diagnosis of each condition. We try to also understand the normal neonatal chest X-ray and the ultrasound patterns. And we also want to understand the role of imaging during the management of these patients of respiratory distress and some of the complications. So what are the different modalities that we have? Whenever you try to answer any question, um, in your exams also, always go in this order only. First, you have to deal with the conventional imaging, then you have to go for ultrasound, and then the advanced imaging, which can have CT, MRI, or if there is some role of nuclear medicine, like for example, patient has PET CT or bone scan. So this is the again the order that I always tell my residents, that this is the order in which you have to basically answer any question which has the this role of imaging, right? So in conventional, you can have X-ray, and if you're dealing with some abdomen question, you have to also mention about the barium studies. So this was not related to this topic. So what is the role of different imaging modalities? X-rays are basically the primary modality. Why? Because mostly these X-rays can be done bedside for the patient. You will see that in most of the hospitals, you have this portable X-ray machine, which goes from bed to bed in your ICU and takes the X-rays. And even the pediatricians are always available, and they also see these X-rays, right? So you have to always have some knowledge which is above them, and they should come to you asking questions, not the vice versa, right? So whenever you go, whenever you are dealing with a neonatal X-ray, always look at the clinical picture of the patient and do not hesitate in asking for the file of the patient, because you do not know what is the age of the patient during delivery. And because all these pathologies that we are going to read, most of them, they look similar on X-ray. It is just the clinical presentation, the age of the patient, which tells us there is some that okay, this particular finding can be the answer, right? So, X-ray is the primary modality. It tells us about the lung fields, as well as it tells about the position of the endotracheal tube is the patient, if the patient has been intubated. Then again, it is a handy modality, so it can be used for follow-up. But the problem with X-rays is again the radiation dose. So you cannot basically do n number of X-rays for any pediatric patient. Units are themselves very sensitive to radiation. So you have to look at the risk benefit ratio of the particular imaging modality. Then sonography, it is basically non-ionizing, there is no ionizing radiation. So how can we utilize sonography in an ICU setting is a separate topic that you have to read, because since the COVID time, this is a very, you can say a very new question, and very, everybody is after it, and you should know about the findings of the sonography in how we use it in the ICU setting. We'll be covering the part of sonography that might be useful to us as we go along in the neonates. So sometimes not just the X-ray you will be required to deal with. Sometimes in NICU you will also get calls regarding the chest sonography of the patient, so that you can say that how is the progression of the, if the medicines are working or not, if the normal A line pattern of the lung is visible or not. So these are the findings, because we want to avoid some of the X-rays. So that is why sonography is something which is upcoming, and you will find online many papers that are also dealing with the findings of sonography in ICU. Right. Then again, CT scan and MRI are usually, CT scan is usually avoided in children unless and until the child is very sick and we are not able to, first of all, in the medical causes, we are telling. In the medical causes, mostly chest X-ray, if it does not give the answer, or they are equivocal and the patient is not improving, then CT scan is the next modality of choice. However, for the surgical findings, for the surgical causes, it is a treatment of choice. And always, whenever you get a CT done for a neonate, always remember that if the NCCT is not required, do not take it. And based on the chest X-ray finding, you have a particular differential in your mind. So my advice is always to get a CCT chest done without the NCCT. And in most of the cases, you will be able to diagnose the condition, whether it is sequestration or it is congenital lobar emphysema, or even it is CPAM. But why are we actually interested in CCD chest? Because if it is a sequestration, we want to see the supply of the sequestration, right? Sequestration is basically an extra tissue of the lung, which is supplied by the systemic arteries, but it can drain into the systemic or the pulmonary veins, right? And based on that, we classify it into um, intralobar and extralobar. We'll be reading this in detail later. So CCT has to be done in all patients in which you suspect a surgical cause. That is one thing that you have to take away today. Do not order an HRCT or a NCCT just to save time. It will give you no information regarding this. Right. Then again, MRI is it has a very long duration for imaging and has high noise in children because of the small size. However, in cases of pulmonary sequestration, sometimes MRI can be done. If we are sure that we are dealing with a pulmonary sequestration, we might order a CMRI. Again, contrast is important. Why? Because we want to see the arterial as well as the venous drainage of this particular sequestered segment so that we can actually classify it into intralobar or extralobar sequestration. Right. So these are the different modalities that we deal with. So coming to the neonatal radiography. So first of all, you have to know that what is the dose of radiation. So you have to minimize the dose of radiation that is being given to the child. How can you reduce this? You have to decrease the FOV and you have to decrease the KVP and MAS, right? MAS both are decreased for the children and minimum radiation is given to the child so that we can get the maximum information. You should always use these shields, right? You have to use the gonadal shields and sometimes thyroid and um, orbital shields can also be used for the children. If possible, gonad shield should always and always be used in children. Then in most cases, we take a AP radiograph where the child is actually lying in the cot and we put the X-ray tube is here and we put the radiation downwards, and that is why the most of the X-rays are done in AP radiograph. Then again, you have to know that the AP diameter of the AP diameter is more in children, right? Then you have to look at if the adequacy of inspiration is there. What is the adequate number of ribs that we have to calculate? So the ideal number of posterior ribs should be the lungs should be at the level of the posterior eighth rib. That is the according to the rib, or seven intercostal spaces, right? Seven intercostal spaces. This is the correct inspiration for the child. If it is less than this, then it is a inadequate inspiration, and if it is more than this, then it can either be a hyperinflated lung fields or you are dealing with some or the other pathology. Then it is important to immobilize the child so that the artifacts gets reduced and you can get a better image of the chest. And then again, I told you that thymus is one thing that is enlarged in children. We all know that thymus lies in the superior mediastinum, and in the children it is actually very large in size and it regresses with the age in size. So do not get confused with the thymus whenever you're dealing with the neonatal X-rays. Right. So how do we reduce the dose basically?